Thank you for joining us today in our Zoom call. And for those of you who might be listening later, thank you for joining us for this session. We're really excited to have our continued relationship at the Mind Institute and the UC Davis School of Medicine. We're a new forming SIG on campus known as the Developing Mind SIG. And again, we're really excited to collaborate to help put on our third talk already of the year. Overall, our goals are just to really help improve and increase education in our community on how us as healthcare providers and colleagues, teachers, and how we can better provide our care and services for individuals in our community who do have disabilities. And so again, keep an eye out. We do have our fourth event coming up in April now. So we'll be sending out more information soon. I will pass it on to Lisbeth, who's here to introduce our wonderful speaker today.
Thanks, Rupa. So today we have our wonderful speaker, Diana Cejas. She's a pediatric neurologist and writer at the University of Carolina at Chapel Hill. She obtained her MD at Howard University and her MPH in maternal and child health at George Washington University, prior to completing general pediatrics training at Tulane at the Oshner Pediatric Residency Program, and then she went on to do pediatric neurology training at the University of Chicago. After training was complete, she returned home to North Carolina to practice medicine and spend time with her family and to write. Dr. Cejas is faculty at the Carolina Institute for Developmental Disabilities. Through her clinical work, she cares for children and young adults with a broad spectrum of developmental disabilities with complex neurological and psychiatric comorbidities. She seeks to improve health outcomes in this population as they transition to adulthood and serves as principal investigator of several studies that explore their unique experiences. After experiencing a critical illness during her residency training, Dr. Cejas has devoted much of her career to improving communication between healthcare providers and the disability community, particularly young disabled patients of color. She speaks on patient advocacy in various venues. She shares her own story and other commentary on disability and health topics through essays, op-eds, and other works of creative nonfiction. Her work has appeared or is forthcoming in medical journals, including the Journal of American Medical Association and Neurology, literary magazines, including the Iowa Review, Catapult, and Passages North, among others. Currently, she is working on a collection of essays that describe her life as both a patient and a physician. So here to start is Diana.
All right, so thank you for that very warm welcome. I am so pleased to be joining you today. A couple of things I wanted to share up front. I'm actually here, I'm on vacation, and I'm spending a little time with my family on our farm. So you might hear some noises in the background, like my neighbor who keeps trying to mow our lawn for some reason, or my grandmother who's digging holes in the garden. I don't know. We also have honeybees that keep flying over and sitting on my keyboard here. So if you hear any sounds in the background, I apologize in advance. I'm also wanted to take the time to say that if anybody has any trouble hearing me, needs me to speak a little bit more slowly. Sometimes when I get excited, I start speaking very quickly, and also I get a little dysarthric. So please feel free to let me know if you need me to repeat something or if you'd like me to make a certain point over again. Anytime I give a lecture like this, I like to have it to be less of a didactic session, more of a conversation. So what I think I'll do is try to see if I can share a little bit about you, share a little bit about myself. Sorry, I'm letting the dog in the house. Talk about how it is that I came to my current position and also came to do the work that I do as far as my research and advocacy efforts are concerned. And then I thought that I might just kind of open the floor, start taking a few questions and see how things lead from there. So with that being said, again, thank you, Liz, for giving that nice introduction. I'm Diana Cejas. My pronouns are she, her, hers, and I am faculty of the Department of Neurology at UNC Chapel Hill. I'm a pediatric neurologist by training. I am also CIDD faculty, and at CIDD, we provide clinical care, research, and education for people with neurodevelopmental disabilities of all kinds across their lifespan. How I ended up kind of coming to this work. In addition to doing the clinical work that I do, I also, as Liz mentioned, I am involved in research. I'm really interested in understanding really patient perspectives on how we can make the care that we provide them better. What can we do to provide better services? What can we do to make sure that we are really getting patients what they need in order to be as happy and healthy as they possibly can with their healthcare, and to be able to understand it and feel like they're more engaged and have ownership in their care. In particular, the vast majority of my patients have autism spectrum conditions. And so those are the patients that I tend to want to collaborate with and learn from in my own research. Before I came to neurology, for a little while, I thought I wanted to be an adolescent medicine physician. And I still have a really soft spot in my heart for adolescents. So most of my research focuses around the transition to adulthood, and particularly the transition to adult care, going from pediatric to adult medicine. I'm really interested in learning how we can help, especially adolescents and young adults with neurodevelopmental disabilities, understand how to engage with the healthcare system and really feel empowered to take care of their own healthcare needs, to contact their doctors, to advocate for themselves, not just in the clinical space, but in wider spaces as well. Um, and really, when it comes to my advocacy work, I'm all about really trying to see if we can improve conditions and the care that we provide for young disabled patients, particularly disabled patients of color. And I kind of like to say that I live in the disability space full time. I work in disability. Everything that I do as far as research is concerned is in disability. And I'm living 24/7 as a person with disabilities myself. So the advocacy work that I do, even though I don't identify as a person with a neurodevelopmental disability, I definitely see the work that I'm doing as some kind of intersectional lens on trying to be a disability advocate. So to get back to how it is that I got here, so when I was in my first year of medical school, for those of y'all who are in your first year of med school, you know exactly what that feels like and just how hectic it is and how it is a lot of transitionings, a lot of things going on at once. But sometime towards the middle of my first year, I found a mass in my neck on the right side here. And, at first, I'm sure that y'all have all heard, all of you medical students, like, oh, you're going to think that you have everything. Every medical student that learns about TB thinks that they have TB. So I tried to talk myself out of it being something for a while. I remember actually standing outside the anatomy lab when we were doing a neck dissection and taking a look at the patient's neck, knowing that I had this mass here. And I kind of stood with my friends and said, hey, can you check this out? What do y'all think about this? And they poked it and they said, we were all first year medical students at the time. And they're like, yeah, you should probably get that checked out. So that is what started my diagnostic journey. I went to student health because, at the time, and actually immediately prior to entering medical school, I didn't have health insurance myself. So I relied on the student health system for my care. Um, and went to see them. They said it's probably just a swollen lymph node. Don't worry about it. Gave me some antibiotics, told me to go home, and said everything would be okay. And unfortunately, that is what I continued to hear over the next few years. I went and back to student health multiple times as this mass continued to grow and I started to develop other symptoms. Um, at some point, I got to the point where I could ask another physician and got told the same thing. Kept going back, kept asking, went to the point where by my fourth year of medical school, I was actually on an ENT rotation and I pulled the attending to the side and said, listen, can you listen to me? Can you help me? I have this thing here and everybody's saying that it's nothing. Can you check it out? And he did, even though I still don't know if that was my most professional of moments. But he said the same thing. He was like, it's nothing, don't worry about it. Go on and let everything be okay. So I tried to just let everything be okay. I tried to let it go. But I think, and one of the things that I like to share, even with my own patients, is that, you know your body best. I might be an expert in neurological disease, but I might not be the expert in you. So I am stubborn and kept going back to different doctors. By that point, I moved from medical school, started my residency training, found a new PCP, went to her, showed her the same thing, and she was like, you know what? No, it's nothing. My second year of residency, we were on, Q4 call, Q3 or 4, depending on what service we were on. But I remember there was one night It was a particularly bad call night. It was just exhausted. I was in the hospital for something like 33 hours or something like that. I came home and all I wanted to do was sleep. But I had been having some pain at the side of the mass, which was now pretty big and fixed in place and had some lymph nodes laying on top of it, which I didn't like either. Um, and I was having some issues where sometimes I would feel a little lightheaded, a little dizzy. I would say, oh, well, maybe it's just because I've been in the hospital for so long. I just need to sleep. I just need to eat. And one night after this particularly bad call, I just wanted to go to bed. And I tried and I could not sleep because the pain was so bad. So I was like, okay, I know that I'm physically exhausted. I know that I want to sleep. I cannot sleep because this is keeping me awake. Something has to give. So I went back to my PCP and basically first presented myself as if I was presenting any other patient and talked about all the signs, talked about all the symptoms. And at the end of that, she was like, yeah, you know what? I probably wouldn't, look that up, but don't worry, it's nothing. And, basically had kind of a hissy fit, and she agreed to get a CT scan, I think mostly to shut me up. And that's when we found my tumor. Um, as it turned out, I had a carotid body paraganglioma, one of those tumors that you learn about in medical school and then apparently never hear about again. So I started going down that pathway where I was going to get worked up. At the time, we thought it was going to be benign because most of the time they are. But as you can imagine, we found out that wasn't true in my case. So I had a first surgery to remove the tumor itself, and then they sent the pathology off, found out that it was malignant. So I had to start going down the cancer pathway, have all that workup done. We planned to have a second surgery where we would determine whether or not I needed radiation, chemo, those kinds of things. All of this is going on right at the beginning of my between the second and third year of my residency. So again, you can imagine the stress that I was under at the time. And the plan was that, on July 2nd of 2012, I would have a modified radical neck dissection, be out for, I think the plan was for 2 weeks, depending on whether or not I need radiation chemo, and otherwise to just continue my residency as planned. Well, things didn't go as planned. Unfortunately, around midnight on July 4th of 2012, I started developing neurological symptoms, and that's when I had my stroke. After that, I was in the neuro ICU for a while. When I woke up, I was intubated, sedated. I couldn't breathe on my own, certainly couldn't swallow my own secretions. I was extubated fairly quickly, but had a lot of trouble swallowing, a lot of trouble speaking, and my left side was entirely paralyzed. So now I've gone from having this cancer thing to now I'm also a stroke patient in a very, very quick period of time. I was lucky in that I was able to regain function of my left leg pretty quickly, but my left arm took a while, and it is still, I feel like it's a very, very real looking kind of, I don't want to say prosthesis, I feel like that's a little insensitive, but my hand, it looks like it moves pretty well, but it's weaker on this side. I'm hyperreflexive on this side, and I have sensory deficits, meaning that I pretty much cannot feel almost anything in this hand to this day, and that's going to be permanent. And I have some other conditions that have developed as a result of my various medical issues. So all of this is happening while I'm finishing up my residency. I felt like I was totally lost, wasn't sure what to do. I was lucky in that my program directors worked with me and were very supportive about everything. I took off a lot of time because I had to be in physical therapy, occupational therapy, speech therapy for quite a while. But we were able to kind of develop a modified schedule for me. And luckily I had front loaded so many of my required rotations that a lot of the heavier stuff I didn't have to worry about during my final year of training. But it was a lot for me to get used to, and a lot for anyone to get used to. I mean, thinking about just trying to come out of residency. I ended up taking a year off, and I know that it always sounds funny to say that I took a year off to go to grad school, but that's what I did, just so I could focus on trying to figure out who I was in this new body with these new disabilities, let alone figure out what I was doing with my life before I went into my neuro training at University of Chicago. And I think I knew going in that it was going to be difficult for me. So for those of y'all who aren't as familiar with that university. So that the hospital is home to a cancer center, a fairly large cancer center, as a matter of fact, and also a very large stroke center. And as a pediatric neurologist, you spend 1 year on adult neurology, which meant I had to spend a lot of time responding to stroke codes. I was often the first responder. I had to spend a lot of time working with people with neuroendocrine tumors and other tumors like mine. And then also had to spend a lot of time working with other people who had symptoms for whatever neurological reason, but symptoms that were a lot like mine. And as I was trying to kind of figure out, how I was processing my thoughts and feelings about these experiences, I'm also still learning how to be a doctor, how to be a neurologist. One of the things I started to learn very quickly was that a lot of the stories that my patients would tell me were a lot like my own story. They would talk about how they were having trouble getting access to certain services. I had trouble accessing those services. They would talk about, especially young women of color, would talk about how people did not believe their symptoms. They had had symptoms for so long and they couldn't get anybody to take them seriously. And I was like, well, that was me for 5 years. Or they would talk about issues, particularly around their disability and chronic illnesses, where they weren't necessarily concerned about having the disability itself. They didn't feel disabled. What disabled them was that they didn't have access to the kind of services that they needed. They weren't able to go to a restaurant that they wanted to go to with their friends. They weren't able to just use any particular public transit area where they relied on really unreliable disability services as far as public transit was concerned. It was things like they wanted to get married to the person that they loved and they couldn't because they would lose their disability benefits. These are things that patients are dealing with all the time. And as I would sit and talk to them, I was like, well, somebody should be listening to these stories. There should be something that we're doing to get those stories out. And I think that that's what's really kind of got me going down the pathway of doing more mixed methods and qualitative kinds of research and trying to figure out how you can use that to design clinical programs that affect the patients. So after a while, not necessarily for myself, but mostly for my patients, I just kind of started getting angry about things. And I was like, there's got to be something that we can do so that we are better able to communicate with patients. Because it's not that I think that physicians are trying to be like maliciously like mean to anybody. I think that it's like we don't do a good enough job in understanding where patients are coming from. And we don't do a good enough job in trying to say, let me make sure that you understand what I'm saying. We get so used to speaking in our own kind of medical jargon. We get so used to kind of talking at a level that maybe a patient might not be able to connect with. Maybe they're not able to engage with that. Or sometimes we just think that we need to be a little bit paternalistic in the way that we do things and say, okay, we need to do it this way so that, because this way is the best way. And maybe the patient has their own ways of doing things, or maybe they have their own ways of thinking about how their care needs to go. There is a lot of something else I don't think that we acknowledge as often as we should is the power dynamics that are involved. And I think if we can just kind of reframe it so that we're looking at this like I'm not your doctor, like to dictate to you. I'm your doctor to partner with you. What I'm trying to do is make sure that you live the happiest, healthiest life that you can. I need you to kind of tell me how it is that we can make that happen. I feel like I have the medical know-how, you have the lived experience. Let's work together so that we can kind of try to figure out how we can use those two things to make the best plan for you so that we have the best outcomes. So again, I started getting interested in doing some qualitative research so that I could do semi-structured interviews, focus groups, things like that, to learn more about the care that my patients need. Right now, I'm trying to, waiting for the IRB to approve, we'll see, a study where I will basically go to patients and parents. And by my patient population, I'm looking at patients with neurodevelopmental disabilities, including those with intellectual disabilities, but mostly patients with autism spectrum conditions, and parents or caregivers of patients with those conditions, and looking and saying, hey, you know what? Around the transition to adulthood, around the transition from pediatric to adult care, these are the things that we think that we do. These are the guidelines that we have. Is this working for you? What kind of services have you gotten? What did work for you? What didn't work for you? And then working with an advisory board of patients and parents with those kinds of conditions to say, these are the clinical services that we offer. How can we make this better? So it's really more of a collaboration so that we can really try to see if we can't make a program that is most effective for the patient's needs. Something that they're going to use, and then also something that we as physicians can use and feel comfortable using. So hopefully we'll see. It's the kind of thing that's going to be great for everyone. Um, Other things as far as my advocacy is concerned is, again, I feel like I just kind of gotten a little bit mad and fired up about trying to make sure that patient voices are heard. So one of the things that I've been doing is really gotten into written advocacy, digital advocacy. Um, Something I've been doing since I was a small child is writing. I've always kind of written short stories and really bad poetry, but I also write a lot of essays. Just straightforward essays, things that are a little bit more lyrical, where you're combining poetry with prose, and then opinion pieces and things like that. I stopped writing for quite a while, and I want this to be a piece of advice for all medical students. Don't let med school stop you from doing things that you actually like to do. You need those things to be a person. It's okay to keep writing if that's something that you like to do. But I'll freely admit that I stopped writing for a while at med school, other than to every once in a while maybe jot down a story idea on a notebook somewhere and then not get back to it. And then after my illness, so many people were like, you should write about this, you should write about it. And I really, honestly, I couldn't. I don't think I could until I felt ready to process some of the feelings and emotions that I had about it. But then one day, while I was sitting in the EEG lab during my second year of neurology training, it was actually right before my third, I think it was second year, third stroke anniversary. And I just felt this urge to sit and write. So I had my phone, I like picked it up. I was writing down this little essay. I know that my attending was trying to teach me something because I'm sitting next to him in the EEG lab. I still have no idea what he was talking about, but he was just convinced that I was sitting there taking notes furiously when I was actually writing an essay. I posted a version of it on Facebook, and then one of my co-residents nagged me with love until I decided to send it out somewhere, and that ended up being my first publication, which was in JAMA, that's not bad. And then kind of here and there, I would write some essays, send them off, not expect anything of it, but they got published a few different times. After at some point, I started to realize, mostly through the fact that I would get emails from people who would say, I read your essay, this really resonated with me, I'm going through something else. I was like, wow, this is a really powerful tool that I have that I can use to tell these stories that I'm hearing, to try to see if we can advocate for change. That's when I started writing more opinion pieces, and that's when I also started writing not just for the medical space, but also for literary magazines. I also write for popular media, and a lot of more medical focused things. But what I'm trying to do is tell the same story, but just tell it in different locations so that different audiences can get used to it. My digital advocacy, as far as that was concerned, also kind of translated to me getting more involved in social media advocacy. Twitter, of all things, I certainly wouldn't have thought I would be as active on there as I am. But that's also another place where I see that as an opportunity for me to talk about things that are important to the disability community. One of the things that I noticed as I started to follow people and grow my whatever on Twitter is that there would be topics that the entire disability Twitter would be talking about, be very excited about, be very vocal about. And I would look at medical or physicians and other medical um, providers and see that they're not talking about those things at all. So I'm like, well, why is it this is something that is so important to our patients? Because so many of our patients have disabilities and chronic illnesses. But there's crickets over here when we're looking at the medical space of Twitter. Why can't we come together again where you have patients and doctors kind of talking about the same topics in whatever space it is that we're going to be communicating? So I feel like my little corner of the world is to just kind of be one of those bridges to be like, look, I'm a person with a disability. Look, I'm also a physician. How can we, again, come together to talk about these topics, and partner better and communicate with each other, because it just seems like they're so separate and they really shouldn't be. Another thing that I felt I've been able to do as far as that's concerned is be, very vocal about the fact that I am a physician. I have disabilities. Yes, I do. It's not wrong to be disabled. It is just a thing that is part of me, and that is just a thing that it is. And so I've gotten to interact with a lot of trainees and have them, learn more about things like being a physician with a chronic medical condition, or, just being in healthcare in general, the kind of things that the kind of barriers that you might face to that. And I'm definitely have a different perspective than some of my other colleagues, like docs with disabilities, might have, and that, my disabilities are mostly physical, although, there are other doctors that I've met that have sensory disabilities, certainly other doctors with neurodevelopmental disabilities. We've kind of come up with this community, which has been just wonderful, to interact with these people, and wonderful because it helps me teach the next generation of physicians. Um, and then other things I've gotten to, I think, do is just show potential applicants. Like, yes, you can be a doctor and have a chronic illness. You can be a doctor and have a disability. You can be a doctor and belong to multiply marginalized groups. It's going to be hard. But here are people like me, and we can serve as kind of, I don't want to say I'm a role model. It doesn't feel like it, but I can at least be an example. I think that's important for the disability community to see as well, because again, if they know that there's someone who has this kind of perspective, who knows what you're going through, I think that that helps our relationships with our patients as well. All of that led to a couple of times when I've been able to advocate on like state and federal legislative levels. I've been at, Capitol Hill a couple of different times and advocated for patients with chronic illness. Also has gotten me involved with like Pediatric Academic Society, and working on an advocacy effort with that group. And so that's how it is, I guess, that I'm here. And this is this kind of mishmash of different things that I do. Um, and I feel like everything all kinds of relates, everything that I do relates back to disability in some way. There's one of our honeybees. And everything that I do, I think, works with everything that I do. I don't know if that makes any sense. Clinically, when I'm taking a history, all I'm doing is trying to get the patient to tell me a story about themselves. If I'm sharing my story, in an essay, an opinion piece, whatever, I'm usually talking about the same themes. If I'm giving a lecture, something like this, or I'm giving a more formal lecture with my residents or my medical students, we're talking about the same things. I feel like I'm just doing the same thing, and I'm just trying to make things better for our disabled patients, particularly those who are most marginalized. And I just do it a lot of different ways. I'm an academic physician, so I guess that's how that goes. So that was a lot of rambling about myself. What I'd like to do is see if anybody has any questions. I'm going to try to see if I can. I know that we're going to facilitate, but I can also try to see if I can look in the chat, or if there's any anecdotes that anybody would like to share. I would like to open the floor.
Hi, Diana. Thank you so much for sharing your story. It was really incredible to hear, and you shared very much. So thank you. I just had a question, because it sounds like from your story, you're saying that you've seen physicians over the course of 4 or 5 years. And even though everyone sees this mass, no one says anything about it. They say, oh, it's fine. Did you have, I mean, at some point you did say, hey, like, I want a CT scan, right? But did you ever have that thought before, or you thought, oh, let me just, they'll know it's okay? Like, what was that like? Maybe did you have any internal discussion about that?
Yes, quite a few. And I think one of the hardest things for me while I was in that period where I wasn't sure what was going on was that I knew something was wrong. I knew it just kind of in my heart, but then I also knew it by the fact that I was in medical school learning about all of the bad signs of a tumor, and I had them. So, I mean, I'm looking in that my tumor is very slow growing. So, it wasn't like I had the time to kind of wonder and think about all of these things. But I think that, again, I think that we as physicians sometimes forget about the power that we have, even over a medical student. I mean, even over, I don't have to tell medical students what kind of physicians power physicians have, but I was sitting here like and work. It's like I'm trying to get to where you are. You're telling me that I'm fine, so then I must be fine. I must be the one who's wrong. I think we as physicians have to recognize that we hold a lot of power over patients. And if enough physicians tell you, everything's fine, you're totally great, everything's good, you're going to start to believe that, even if you in your heart know that that's not the truth. I think the only reason why things were a little bit different for me was because I had that medical knowledge. I know, I sat in those pathology lectures. I was able to see those slides in my histology courses. Um, but I think about my patients who don't have that background, who aren't able to advocate for themselves. I think that me being a doctor, when I actually got my diagnosis, had a lot to do with why I got the CT scan in the first place. Because again, I joke about it and say, I think that she did it to shut me up. But I really think that she probably did it also because, she respected the fact that I was a physician. I was a resident. And there are definitely power dynamics and hierarchies there too, but I was still someone with an MD coming to her saying, I have a problem, can you look at it? I think that Dr. Sejas, have a lot more power than just Diana from Rougemont. So thinking about, my patients who don't have a medical background, who maybe aren't highly educated, who maybe have a low literacy, maybe English is not their first language, thinking about trying to advocate how they can advocate for themselves, it's just a lot for patients to have to kind of jump through. Um, so I think that, one of the things that we physicians can try to do to try to see if we can provide better care is allow our patients to question. And that sounds like it's a weird thing to say, like allow a patient to question you. But I know even if a patient questions me, sometimes I'll be like, well, I'll be a little bit affronted or taken aback, but it's like, okay, well, I have to remember what it is that I'm looking at here. I need to give the patient time and space to think about what we've talked about. I need to give them the opportunity to ask questions. I need to make sure that they understand exactly what I'm talking about. Because again, I'm the one who's holding all the cards here. I'm the one who's holding all the power. Um, so I think that was a long-winded answer to that question. Did I think about, what all this meant? I mean, I definitely did, but there were certainly times when I'm like, you're the expert, so I obviously don't know what I'm talking about, even though it turned. I don't think I'm not sure if I knew that it was cancer, but I knew that it was something. I knew that something was wrong, and I also knew that I didn't feel like I could question that until I got to the point where I was like, no, I'm not taking no for an answer.
Thank you for that really detailed response. I appreciate it. I agree. It feels like sometimes we have so much trust in our providers too, right? But then there are also the times we do need to fight more to be heard.
Yeah.
I have a sister with the special needs, and it feels like sometimes we have to be a little extra aggressive in a way to get the physician, let's say, to do an ultrasound, like of her breast, for example, if you know that there's lumps there or something. So, no,
Yeah.
definitely, thank you for sharing.
Yeah, I don't think that this is I mean, it's a problem and it's like a systemic issue. Again, I'm not saying any of these things to like villainize physicians or anything like that. I mean, I wouldn't be a physician if I didn't think that we have, we can do amazing things for people. It's just that the way that medicine has been set up traditionally, it's very paternalistic. It's incredibly like just laden with all kinds of biases. And certainly when you start laying other things like good old fashioned sexism, racism, ableism, and all those things on top. You might be a perfectly wonderful, good person, but you're still working in this system that is not designed to help those who are most marginalized. So I think, again, yeah, just I wish that stories like mine were less common, but unfortunately they are not. One good thing I will say is that it seems like more people are getting vocal about the fact that, you know, situations like this happen and more people in healthcare are recognizing that it's an issue and we need to make some change.
Hi, Deanna. Thank you again for sharing your experience with us and for discussing your practice too. Something I was really interested in was your study that you're going to be taking on, looking at that transition from childhood to adulthood. And I know that there have been other studies that show that a lot of adult practitioners just aren't prepared to take on that transition. So I'm curious, like, what are your thoughts of like, what ways can be incorporated into adult training that's already sounding like it's pretty gruesome. Like there's a lot that's incorporated into like internal medicine or family medicine and just that transition. So I'm wondering, do you have any ideas or suggestions that you think should be incorporated in that training to facilitate that transition from childhood? Because if I'm not mistaken too, I'm rambling, sorry. Um, that transition isn't until about 21 years old. So already they had some adult care from their pediatrician, but now they're transitioning to somebody who usually sees someone significantly older than they are.
Mhm. Yes, you are. I feel like this is a very timely question for me because this is an argument that I'm having right now with my adult neurology colleagues. So you're absolutely right. As far as healthcare transition is concerned, just point blank period, we're terrible at it. And that's for kids with any chronic illness. But for the patients that I serve, patients with neurodevelopmental disabilities, we're even worse. I think that there are multiple reasons for that. Just again, to be very frank, a lot of the patients that I serve with the medical complexities that they have, they would have been expected to live past, their late teens, early 20s, maybe 50, 60 years ago. Luckily, we have improved our supportive care. We've got improved diagnosis, improved surveillance, all kinds of different wonderful technological advancements. That means that children who would have died in their teens, in the 40s, are living now into their 50s, 60s, and 70s. The problem, I think, as far as our adult medicine colleagues are concerned, is that the training has not kept up. I cannot tell you how many times I have talked to neurologists, particularly the trainees, because I think one thing that is starting to trickle in is that trainees are more aware of healthcare transition issues. Trainees are more aware of the fact that they're going to have to take on those patients. So I've talked to a lot of adult neurology residents who have been like, you know what, I don't know what to do with this patient when they come to me. They can say, I can take care of a patient who has had a stroke and he's 72, but they have no idea what to do with a 21-year-old who's had epilepsy since they were 3 days old. I think that what we can do is, first of all, I think we're going to have to, certainly in neurology, do better about our education around developmental neurology, not just for pediatric neurologists, but also for the adult neurologists. As I kind of mentioned, in peds neuro, we have to spend a year of adult. For adult neurologists, I think they only have to spend 3 months of pediatric training altogether. And that's over the course of 4 years of training. That might just be me thinking about the programs that I've interacted with, but it's really not that much. And you think about how much time you're going to spend focused on, adult issues. Most of the time you're going to be learning about things like strokes, headaches, those epilepsy, those MS, maybe those kinds of things. But we really need to do better to prepare our adult colleagues to know a little bit more about neurodevelopmental and childhood neurological conditions, because they're going to be the ones that get them. And I feel like there has been, again, a little bit of a pushback, because in child neurology, we are really bad about transitioning our patients. But part of the reason I think that we're really bad about transitioning our patients is because we've got no one to transition them to. I think if we can do better, and that's one of my personal missions in our training program, is to try to make peds neurology a little bit less terrifying to the adult trainees. But I think that's really the step one, is try to get medical students and residents to know that healthcare transition is something that you should be learning about no matter what field you go into. Because, as a pediatric neurologist, I still take care of people into their 20s and 30s, depending on what kind of condition they have. As an adult provider, if I was an adult neurologist, I'd be expected to take on people who are in their teens and coming up. So we have to know about what these conditions are going to look like in adolescence, how puberty affects these things, what other kinds of issues young adults might be dealing with when they're dealing with chronic illness. So I can say we're going to have to rethink the way that we approach our education. We're going to have to spend a little bit better time preparing our adult providers. And then it can't just be, at least the way that I see it, is that we also have to, at the time of the transition itself, do a little bit better job communicating. I'm lucky in that I'm in an academic institution. I know my adult colleagues. I can say, hey, I have a patient, I want to transfer them to you, we can have those discussions. But if I was, in private practice somewhere, it might be a lot different, and I might need to do more in terms of planning how we're going to communicate with the accepting provider. It can't just be here's this kid I've been following since he was literally fresh out the womb, and now I'm giving him to you 21 years later. It has to be more of an ongoing conversation. Again, more partnerships between adults and peds, and knowing that all we're trying to do is make sure that everybody just stays as happy and healthy as they can. That's what we're all trying to do. So we can just collaborate a little better. And it looks like someone else asked a question in the chat about how do I encourage families to support the transition from pediatric to adult care. I start early. And I know, depending on if you look at the transition literature, and if anybody's interested in this topic, I would highly, highly suggest your first stop could be the GOT Transition website. GOT Transition and the 6 core elements of healthcare transition is kind of like, almost like the Bible in our line of work. But that has a lot of resources, tells you what you should expect from healthcare transition, what you should do as a provider, and has all kinds of resources for patient and parent education. What I do is for GOT transition, they say that you should start around, anywhere between 12 and 14. For me, if I've got a family, especially I've got a family who's thinking about like, maybe this is a kid who could be a little bit more independent. Maybe they'll be moving outside the home, but they've got a lot going on. I tend to start early. So maybe 12, maybe even earlier, I might give the parents a heads up starting around 11 to say, hey, we need to start talking about healthcare transition. And this is what that means. This is what that entails. It's not just hey, I'm glad to see you, now go see adult neurology. It's really more of a process. So you start talking to them about it earlier. And you don't just talk about what's going to change with your healthcare. It's not just you're going to be seeing a new doctor and that's it. It's also maybe you need a new insurance plan to go see that physician. Maybe we need to talk about whether you're going to be at home, at college, in some kind of supported living environment. Who's going to be managing your medications? Who's going to be helping you make medical decisions? We need to talk about all kinds of different things as we're talking about your move to adulthood. Usually when I'm talking about healthcare transition, either with, families, patients, or trainees, if I'm giving a lecture or something, I'm like, think back to your own adolescence. Think about all the stuff that was going on. Or for those of you who maybe have kids in that age group, think about how many different things are changing all at once. And now throw chronic illness and disability on top of that, and think about all the kinds of ways these kids are going to have to be more independent, or they're going to maybe need some more support. So what I do is start talking early. I start telling them to think about all of these different things. Like, think about what you want for school. Think about where you expect them to be living in 5 years. Think about whether this is a person who's going to be able to drive. Think about whether this is a person who's going to want a family of their own one day. Really just imagine what your life is going to look like. And then we can kind of figure out what we need to do to support you to be able to get you to those goals. Because to me, health is not just about what medications are you taking. It's also about where are you living? Do you have a stable source of food? Are you able to get where you need to go? Are you able to get the education that you want? Are you able to provide for yourself and anybody who comes after you? I think that's a little bit unusual for a neurologist to be interested in this kind of a comprehensive care thing, but particularly for patients with chronic illness affects so much of their lives. So you have to think about all of those different aspects and try to get your families to think about how many different aspects will be affected by this transition. And I see somebody put the GOT transition link in there, so thank you very much. I highly recommend looking at that site if you're interested in this work at all. They also have, I think, a listserv that you can join, and they can send out fun information about like healthcare transition. Sounds like it's like, oh, it's fun to talk about transition. It's fun to me. Maybe it'll be fun to you too. Let's see. I see another comment. I'm not sure if this was a continuation of the previous, talking about as individuals disabilities are living longer, where, oh, I'm sorry, I didn't read that correctly. As individuals with disabilities are living longer, where is the research on aging with a disability? Yes. So there are actually, there's an increasing number of researchers that I've heard about, particularly recently, who are interested in aging with disability. I've heard of some work. So one of my colleagues at CIDD is actually interested in Parkinsonism in patients with Down syndrome who are in their like 50s and 60s. And they also do some work with dementia and Down syndrome in people who are in there maybe, or trisomy 21, I should say, or maybe in their like late 40s, early 50s, because we know that dementia is a thing that we can see in this patient population and it tends to come early. We know also that Parkinsonism is something that we tend to see early. I also know of some other researchers in autism at UNC who are interested in this idea of what happens to support needs as patients age, particularly once they're in their 60s, 70s, and beyond. There are people that are out there doing this kind of work. There's also, I'm trying to think of, I want to say it's a group at Hopkins that's doing some research around autism and aging, but it is becoming an increasingly popular topic, thinking about the needs that healthcare needs and then other needs as well that people with disabilities need and how things change as they age. I think that for me, obviously I'm mostly interested in that like fluctuation period between childhood and adulthood. But there are people that are out there that are doing this work. So if you're interested in it, I'm trying to think of other people who might be. I really want to say that one of the autism centers in California is doing some of this work too. But I can certainly try, if somebody's interested in wanting to know more about that, I can look at my connections and see who I could find and send that out.
Just to follow up, I know you mentioned about having to advocate for yourself, as a medical student, but do you have any advice for medical students with disabilities as they're looking to apply to residency, and how much do they disclose? How do they find a program that's right fit for them? If you can touch on that, that would be great.
Yes, I think it's difficult. And I feel like that is my duty just to tell you that, if you are a student with a chronic illness, disability, whatever, it's going to be a hard road. And trying to find the right fit, I mean, it's hard enough for any patient, any person to find the right residency program for them. But again, you're throwing disability on top of there. It makes things even more complicated. What I say is, and it can be hard to do, but try to look at the culture of a program. So I know for me, when I was looking for a faculty position, I wanted to make sure that it was a place that I would feel comfortable to come and not feel like I was a burden. And I hate the word burden in terms of, disability, but I mean, ableism is real. I know that for the rest of my life, I'm going to have to do things like I'm in physical therapy right now again because of some of my shoulder issues. And I know that that's going to be something that I'm probably going to have to do off and on for the rest of my life. I know that I'm going to have to, be able to get my scans every year, get my labs done every 6 months. I'm going to have flexibility so that I can leave and do those things. So as faculty member, which again is a little bit different because you have a little bit more flexibility now that they actually are trying to recruit you over. One of the things I did was try to look around at other faculty members and see, it's hard to say, I want to see the people there with disabilities because not every disability is visible. But, I noticed that there was, a person on faculty who uses like an assistive equipment, like a walker. I've noticed that there were people that were there with other kinds of physical assistive devices. And I was like, that's a good sign to me. Because at least if nothing else, then, I don't want to say that they accept people with disabilities here because that sounds terrible. But you know what it is that I'm saying. It's like that this person feels comfortable enough to be out here and they're not, at least as far as I know, having any problems. That matters something to me. I think as a student, you can try to see if you can look at the faculty, see if you can find out what their research is in, see if you can find out what you can know about them. Honestly, just kind of, I don't want to say lightly stalk them, but really do. Like if you look me up, you're going to see disability stuff. If you look up my Twitter, you're going to see that I'm out there, I'm open, I say that I have a disability. I think that that has made actually a couple of our applicants this year, I think that that was something that they were really interested in. See if you can't find out if this is a climate where they have either physicians, trainees, faculty, staff, whatever, who have disabilities and who are there and thriving. I think you also, as you are either looking for residency programs or trying to get into medical school, you can ask. I think asking is also a good way to kind of gauge the culture and the environment. You don't necessarily have to disclose. I think as far as disclosure is concerned, again, that is something that is very hard to do. It's very personal, and you have to decide what it is that you are going to be most comfortable talking about. For me, my own, initially I told my program director, and I think maybe 2 or 3 other people, that I was going in for this surgery. But unfortunately, other information about things that I was going to was disclosed without my consent. And then I had people come and visit me, and I still have really complicated feelings about everything that they were able to learn about me and know and see. And you would think the HIPAA is real, but I guess not. But even though I had that experience as a trainee in the program that I was in, I think that one of the things that was the most helpful to me was that leadership was like, you know what, we know what you're going through. And we want you to be here, and we want to make sure that, things are as smooth for you as possible. We don't want to make things worse. So I think that as you're looking around, you can ask, like, has anybody had a chronic illness? Are there residents who have gone through things? Or if you don't feel like going down that chronic illness pathway, ask them how they deal with residents who take time off to take care of like a sick family member, or take time off for maternity leave. If they're like, and I'm thinking about one of my friends who's surgical, he's a surgeon now, but in training, he had a colleague who was in labor operating and then went downstairs, had her baby, and allegedly came back within 2 weeks. I don't want to, that just seems like that's not okay. I don't think that I could, thrive in a program where I was expected to just not take care of myself after something as major as childbirth. So maybe try and find out how they deal with other kinds of life stuff outside of medicine. Then if you feel comfortable enough, you can disclose. And I think that that will give you a lot of information as well. I mean, if you're like, I am a patient with like a visual impairment, a hearing impairment, and they're like, oh, we've never done that before, then you know that maybe that's not the place that you want to be. I don't think you have to disclose everything unless you really feel comfortable about doing it, but I believe that that could give you some information too. I think another thing that any student with a disability or chronic illness should do is to get to know about what kind of programs and services they might offer. For trainees with disabilities, you can usually find that out on their website. Sometimes it takes a lot of hunting, but also the part, if you have to hunt a lot to find out about these policies, that should tell you something about how important they are to the program as well. And then practical stuff like how much leave you get, how much, wellness activities they have planned in, really just anything that can tell you about how much of an outside life you're allowed to have. And that sounds like it's something that's, it sounds like it's so trivial, but I think that that's something that's very important for people to know about. What kind of support you're going to have going into any kind of program. So let's see, and I know that y'all had that question because you were wanting to do the survey. I don't know if we need to give people time to do that survey now. I see that there was one other question about policy issues.
You're fine. You can continue talking. They have a link. If everyone can just click on that link at some point, we'll wrap up here in the next few minutes, but just that would be appreciated.
So another great question in this chat are, what are current policy issues that affect patients with disabilities that we can advocate for? Take your pick. So I think it just kind of depends on what your field of interest is in, your field of interest is. I know that, in neurology for me, some of the things that I've been advocating for lately is, oh geez, I don't even know where to start. I mean, there's certainly prices of medications, because that is something that is just, I don't even know where to start. I mean, it's just horrible the way that things like insulin can cost thousands of dollars. People can't afford that kind of thing. And again, I'm a neurologist. You wouldn't think I'd be, talking so much about insulin, but like medication prices in general, people have to be able to afford those kinds of things. Healthcare, just in general, access to care is something that you can talk about as far as policy issues are concerned. There is actually, I'm thinking about, geez, I just lost it. There's a bill that's actually in Congress right now. I think it's going to come to me. I think that if you're thinking about like you want to get involved with advocacy on a federal level, one of the things that you can start to do is familiarize yourself with different bills that people are thinking about putting on the table. If you already know what kind of specialty that you're going into and they have their own legislative advocacy area of interest, like I know that both the American Academy of Pediatrics and the American Academy of Neurology both have their own legislative advocacy kind of wings. I tend to align more with AAP than AAN because AAN does a lot of stroke advocacy and things like that. And I'm more interested in things like, making sure that children have access to things like SNAP and WIC because my kids, they've got to eat. Other topics that I can think about is housing access, transportation access. There's been a lot of push lately for talk about infrastructure and improving our infrastructure and people with disabilities in particular, especially. And this is a more of a local issue that I've been seeing kind of popping up in multiple different places. A lot of people with physical disabilities, particularly wheelchair users and those who use other equipment like walkers and canes, have been being very vocal about the way that COVID has affected things like our access to sidewalks and access to clear paths. That's something that the community here and the Triangle has been making a lot of noise about lately, because if you're putting all of the restaurant out onto the sidewalk for them to be able to comply with COVID social distancing, people who use wheelchairs are going to be forced to use the road, and it is a hazard and safety issue. So again, there can be all kinds of different things that you can kind of think about. Really, when I think about advocacy, think about what you're most passionate about. And then you can find someone who is kind of like, yes, I agree with you. Like, let's talk about these things. Let's make a change. Other things that I've been working on a lot lately is health equity. I'm actually working on a paper with a group right now where we're going to be talking about how racism and ableism affects children's health in a health equity kind of context. We're trying to see if we can't develop a policy paper for that in particular, and really encouraging legislators to know that, not only is racism a thing and it affects children's health, but also ableism is a thing. And when you have that confluence, racism and ableism together, it can really significantly affect the health of our young disabled patients of color. And so that we can think about, if we're talking about advancing or improving the health improving healthcare in general, we certainly need to be looking at it from this kind of intersectional lens. So yeah, I've been spending a lot of time lately with working on things from a disability advocacy and health equity kind of healthcare reform kind of lens. And thinking about, particularly as the national conversation is talking about like how our healthcare is going to look, whether it needs to be Medicare for all, we really need to just make sure that no matter what our healthcare looks like, that everybody has equitable access to it, particularly those who haven't in the past.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.